Hi, thanks so much everyone for joining us today. We'll just start off by confirming that the speakers today have no commercial relationships to disclose. Next slide, please. Welcome so much to Transforming the Adolescent Health Visit for Youth in Foster Care. This is a talk about how the Los Angeles Reproductive Health Equity Project partnered with physicians and foster youth to address barriers to sexual and reproductive health care. Next slide, please. Today, you'll be hearing from me, Rebecca Gudeman. I'm an attorney at the National Center for Youth Law, as well as several other eminent speakers who will introduce themselves in turn. We also, though, want to acknowledge that much of the work that we'll be talking about today was a collaboration with a number of wonderful people. This slide just acknowledges two of them. There were many more, not the least of which the fabulous partners in our Youth Advisory Board, who are all former foster youth from Los Angeles County. Next slide, please. We also want to make sure that we acknowledge some of the important folks whose funding helped make this work possible, including the UCLA Pritzker Center, the U.S. Health and Human Services Department Office of Population Affairs, and the Conrad and Hilton Foundation. Next slide, please. Today's objectives. We're hoping by the end of this session, you will have all gained a deeper understanding of the unique barriers and facilitators to sexual and reproductive health care for youth in foster care, that you'll be able to discuss this innovative program strategy we'll be describing to you today, the Reproductive Health Navigator for Foster Youth, and its use as a pilot program to facilitate sexual and reproductive health education, as well as linkages to desired services. And finally, that you will have a better understanding of the impact of the adolescent environment to the success of a visit. Next slide. Our agenda, we're going to start by just providing some context and setting the scene, describing child welfare as a reminder and healthcare for youth in foster care. Then provide some information on the current realities around the sexual and reproductive health outcomes for youth in foster care and why this is such an important topic for us all to focus on. And then describe the work that we were doing, partnering to improve sexual and reproductive health care and delivery for youth in foster care. Next slide. All right, we're going to start with the child welfare context. Setting the stage, child welfare, we have in every state a child welfare system. Children ages 0 to 17 enter foster care due to abuse or neglect in the home. In most states, if a child reaches the age of 18 while in care, they have the choice to remain in care until age 21. There are just under 500,000 children in foster care across the country, with 62,000 in California's foster care system alone. 1/3 of those are in LA County. The goal of child welfare is reunification with the family of origin, but that's not always possible. So while most children will stay in foster care for a year or less, there are a significant number of young people who spend many years in foster care. And right now, for example, in California alone, there are over 7,000 young people who were in care when they turned 18 and chose to stay in care. So there are more and more young adults now in the foster care system. Next slide. When we look at ages, adolescents are a large portion of youth in foster care. Nationally, about 35% of young people in the foster care system are between the ages of 11 and 21. And in California, that's about 44% of our foster youth. Next slide. It's also really important to acknowledge that youth in foster care don't look the same as youth in the general population. So for example, when we look at race and ethnicity, we do have youth of color overrepresented in our foster care system, and in particular, youth who identify as Black or African American or Native are significantly overrepresented. So just as an example, in California's child welfare population, while our general population is only 5% Black or African American, 22% of the children in the foster care system identify as Black or African American. Next slide. We also see that young people who identify as LGBTQ+ are significantly overrepresented in child welfare. Nationally, just about 23% of children in the foster care system identify themselves as LGBTQ. And in particular, when we're thinking about healthcare and healthcare access, it's really important to acknowledge the intersections of different identities. So for example, within the LA County child welfare system, 83% of the young people who identify themselves as LGBTQ also identify as either Black or Latinx. Next slide, please. Now, when a state takes a young person into state custody, the state becomes legally responsible for ensuring that that young person receives services to meet their physical and mental health needs. So among other things, every state needs to have a system that provides young people an initial health assessment when they come into the child welfare system, and must have a system in place to provide for regular follow-up health screenings. And then any needs identified during those screens need to be met. The state is responsible for providing treatment to young people in care. Young people in foster care are almost all categorically eligible for Medicaid. So there also is an insurance program available to help ensure that their healthcare needs can be met and paid for. Next slide, please. So with that context and understanding that our states are actually legally responsible for ensuring that young people get the health care they need, let's talk a little bit about the sexual and reproductive health outcomes of young people in foster care. Now, nationally, we've had great success addressing teen pregnancy, and we've seen dramatic reductions in the percentages of teen pregnancy in the general population. So just as an example, in California, since 1991, our teen birth rate has actually gone down 77%. And we see this across, in this slide in particular, we're showing different ethnic and racial groups. We see this across all different groups. However, next slide, please. We don't see the same success with young people in foster care. Next slide. There have been a few surveys of young people in foster care, and in California at age 19, when asked, females who had grown up in foster care, about 50% of those young people said that they had been pregnant at least once in California. This is a rate that's about 2.5 times the pregnancy rate for young people in the general population. That's California, but this isn't unique to California. We see significantly higher rates of pregnancy in foster care across many different states. In fact, in Texas, young women aged 13 to 17 in foster care are nearly 5 times as likely as their peers to become pregnant. Next slide, please. Now, critically, this is not necessarily new data, but what is starting to come out that's new is we're actually asking young people about these pregnancies. And in one pivotal study in California, young people who identified themselves as having had at least one pregnancy were asked, did you want to become pregnant at the time you became pregnant? And of those surveyed, 66% of the young women who said that they had been pregnant did not identify that pregnancy as something that they had wanted or planned for. And 70% of the young men said that they did not. So there's a significant gap between the intention and goal of the young person and their access to the tools and knowledge and ability to actually realize that intention. And that's really important. Next slide, please. We also know that young people in foster care who do become pregnant tend to have worse prenatal and pregnancy outcomes as those in the general population. So there's a number of different data points. This is from the Cal Youth survey done in California of females who at age 17 who reported pregnancy. About 43% reported that they had had a stillbirth or miscarriage. Now, we don't have exactly parallel data for the same age group in the general population, but we know that overall the miscarriage rate for pregnancy is about 15%. So this is of significant concern. We also have 21% of these young people saying that they never received prenatal care. And again, these are young people who are in state custody. The state is responsible for ensuring that their healthcare needs are met. So this is again, a real gap and opportunity to provide better healthcare access. Next slide. We also see disproportionately higher rates of sexually transmitted infection and disease for young people in foster care. So while it varies between males and females and by different STIs, we do see that there are up to 3 times higher rates of STIs for young people in the foster care system. Next slide, please. Now, there's a number of different reasons that we can see different health outcomes for this particular group. It's important to acknowledge the social determinants of health, including adverse childhood experiences. There are many reasons why the ACEs and social determinants of health for young people in foster care are going to look quite different than they are for young people in the general population. Changes in placement, changes in adult support, access to quality health care, access to continuing health care. But we also see some just flat out specific structural barriers to care. Next slide, please. Some of the things that we've been able to document are young people reporting simple logistical barriers, such as lack of transportation. They may be placed in a group home or a home that's very far away from their provider of choice, and they may not have an easy way to get to their healthcare provider. We see inconsistent access to comprehensive sexual health education or to their provider of choice due to placement changes. It's not uncommon for young people in foster care to move homes multiple times in 1 year. We've had young people describe living in more than 16 different homes during their high school years. This makes it really challenging to ensure that they receive the education that they want. It also makes it really difficult to create any kind of continuity of care with a provider or create relationships with the provider that would allow for us to more easily address some of the more sensitive and confidential healthcare issues. We also see for young people in foster care practices that actively infringe on youth rights and access. In California, we've had young people report that their group homes may consider birth control contraband and confiscate it. Young people reporting that when they asked for access to healthcare appointments, they were refused for various reasons by their caregiver, their group home. In California, this actually violates the youth's rights to care, but that's not something that many people know, and that leads to another important structural barrier. In most states, there is very little policy or explicit guidance around the role and responsibility of caregivers, social workers, and others surrounding foster youth. And social workers and caregivers report being concerned that they may be infringing on the role of a parent or breaking some law if they do support provision of sexual and reproductive health care. So the lack of policy and training in and of itself becomes a barrier to care without us setting a stage that ensures that the folks around young people feel safe supporting their access to care. Now, while it differs state to state, we're going to be talking about California. So it's important to know that young people in foster care in California have the same minor consent rights, the same rights to confidential sexual and reproductive health care as do young people in the general population. And they have the right to have contraception of their choice, access to sexual diagnosis and treatment for sexually transmitted infections. So this is something that should be available, but young people have identified that they are hitting these barriers to care. Next slide, please. So with that context, with us hearing more and more about these structural barriers and acknowledging some of the unique influences that make it more difficult for young people in care to access the services that they want, a group of organizations got together to see what they could do. Next slide, please. So today we're going to talk about a relationship between the Los Angeles Reproductive Health Equity Project and all of you UCLA medical hubs. So I'm just going to take a second to describe LA Rep, as we call it, and then I'll pass it to my colleague to talk about the hub. So the Reproductive Health Equity Project for Foster Youth is a public-private partnership that includes a leadership team of both public county agencies, including the Child Welfare Agency for LA County, as well as a number of nonprofits that work in social services, health, and law. And our unified goal is to significantly reduce the inequitable reproductive health outcomes experienced by youth in foster care by increasing access to sexual health care and information. Next slide, please. Now, recognizing that this is a really complex issue, we work in multiple areas. We have interventions and engagement with youth themselves directly, with social workers and child welfare system, with foster caregivers, with the courts, and with healthcare providers. And that's what we're going to talk about a little bit today. But when we talk about interventions, we are both working on state law and policy as well as local child welfare agency policy. We create trainings, tools, technical assistance, and we work a lot on community engagement. And this is critically where our Youth Advisory Board comes into play, because they are always both grounding and centering the work we do in all of these spheres. Okay, at this point, I'm going to pass it to Stacy Barron to talk a little bit about the hub and then introduce the partnership and the work that we've been doing. Stacy?
Great. Thank you so much, Rebecca. For the next part of our workshop today, we're going to discuss the provision of sexual and reproductive health care in a unique set of clinics serving welfare-involved youth in LA County. And so before, again, we discuss our partnership with the LA Reproductive Health Equity Project and our eventual path to the Health Navigator pilot program, I think it's really important to set the context for our clinics. Rebecca mentioned earlier that the state has an obligation to provide initial health assessments to youth who are detained into care. And Los Angeles County has a unique set of 7 clinics dedicated to the care of families involved in our Department of Children and Family Services, or DCFS. So these clinics are called the Medical Hub Clinics. Hub is not an acronym, but rather a framework where multiple disciplines partner with the medical team to function as the spokes of the wheel with the patient at the center. So this simple concept that the patient is at the center of what we do acts as a compass for us, guiding our actions as providers. I am a pediatrician at the All of You UCLA Medical Center Hub. The Hub clinics arose in 2006 as a partnership between the Department of Health Services, the Department of Mental Health, and then the Department of Children and Family Services. And really the goal of the Hub clinics is to guarantee that every child who is detained or at risk for detention has access to expert medical and mental health evaluations, as well as to provide high quality and coordinated health care for children who are system involved. So the Hub clinics see every patient detained into out-of-home placement for an initial medical exam within the first month of that detention, or within 10 days for high-risk patients. And then we see in-home of parent cases on a case-by-case basis. So these initial medical exams provide a really unique opportunity to connect with our adolescent patients. And though the hubs do offer continuity of care, as many of us know who work with adolescents, and particularly those in foster care, follow-up can be very difficult. I have been working with Rebecca and many collaborators to understand ways in which we can maximize this visit for our adolescent patients. And sexual and reproductive health care is an integral topic for this visit. This led me to a partnership with Dr. David Richards, an alumni of the UCLA National Clinician Scholars Program. And together we sought to answer the question in collaboration with LA Rep: how can we improve access to and delivery of sexual and reproductive care for foster youth in the Los Angeles DHS Hub clinics? As a provider, I saw firsthand the sexual and reproductive health disparities that Rebecca described earlier in the presentation. And this collaboration allowed us to brainstorm ways in which we can mitigate these. So again, the goal was to design interventions to overcome barriers to care that were identified by both provider and patient stakeholders. So phase one of the project was to identify and understand provider perspectives on the barriers and facilitators to sexual and reproductive healthcare access for youth in foster care. We interviewed 17 hub providers using a semi-structured interview guide to discuss how and when sexual and reproductive healthcare discussions happen. We also discussed potential barriers to successful care plan execution, as well as ideas for improvement and areas for increased collaboration. We recorded the interviews the interviews were transcribed, and a thematic analysis was performed. And using this qualitative methodology, we identified 4 major themes that go along with the provider perspective. So the first theme, privacy is paramount. For instance, one provider said, I really think that their choice, referring to patients, not to disclose information about their sexual health comes from just a general distrust of institutions. I think that's really the primary reason why they may not open up and why we may not be able to provide services. And another salient quotation, I think the first time your social worker knows what happens at the hub after we promise confidentiality, that's the last time they tell us anything. So our providers felt that privacy was very important to youth, that they needed to know how we were going to protect their privacy, and that the history that's obtained in the visit may come from a fear, or the limit to the history in the visit may come from a fear of the youth that their information may be shared with others. The second theme, you might only get one chance, so seize the moment. As one provider said, reproductive health care for adolescents, it's like one of my number one next to anything that's acute life-threatening. And another provider, as sort of a barrier to this one-time opportunity, is that with this initial health assessment, the vast majority of kids are not ready that day, as one provider stated, and most don't even know why they're there for the visit. So we have this really unique opportunity with this mandated initial health assessment visit, that a lot of youth don't necessarily have a choice in what provider they're going to see for this visit, don't necessarily know all of the different things that are going to be discussed during that visit, including their medical needs, as well as their sexual and reproductive health needs, as well as their history of trauma and mental health needs. And so we have this wonderful one-touch opportunity. We know that there's a lot to discuss in that one-touch opportunity. And we know that sexual and reproductive health care is a very important topic as well. The third theme being promoting youth agency and avoiding coercion. So as one provider stated, you don't have to do anything today, but I want to make sure that you are in charge of your health and that you have the tools that you need to care for yourself in the right way. And just continue to make sure that they know that they have that agency. And this is a difficult thing when it comes to the fact that we have this theme number 2 of seize the day, seize the moment. We want the youth to take the time to have the decision. We're also worried, are they going to come back? What are going to be the barriers to follow up? And we want to make sure they have plenty of time and agency to create a reproductive health plan and to execute on that plan. And then the fourth theme being increased collaboration is in tension with youth privacy concerns. So as one provider stated, when foster parents, group home staff, social workers are supportive, it's awesome and it's such an allyship. And as another provider said, because when we maintain their privacy, we kind of leave it up to them. I don't know that they have the ability or the capacity to navigate the systems and get things done. So we know that our youth have the right to confidentiality about sexual and reproductive health care services. We know that they're afraid that their information is going to be shared with others in spite of this right that they have. But we also know that the system by which patients can get linked to the services that they need is quite complicated. And it can be helpful for them to have a partner in that process. And some of our patients have a great relationship with a mentor or a social worker or a caregiver, and they're willing to have that allyship, and that can make it a lot easier. But when that doesn't exist and the youth has the right to keep this all private, it becomes very hard to actually get end-to-end completion of services. So these are 4 themes from the provider perspective, and the providers really helped us to see that there were both barriers to sexual and reproductive plan creation, such as getting the history, making sure that the youth feels like they have a private space to talk, and realizing what their needs are through that accurate history. And then there's also barriers to plan execution. The system is very complicated, and when there's not a partner and when we leave it up to the youth themselves, it can be very overwhelming to navigate the systems of care, needed to get the services that they need. So in order to properly plan some interventions, not only did we want to incorporate the provider perspective, but it was also really important to us to hear from the youth perspective. During the summer of 2020, we conducted youth listening sessions over Zoom due to the COVID-19 pandemic with members of the LA Reproductive Health Equity Project's Youth Advisory Board. We used, again, a semi-structured interview guide to discuss their experiences receiving sexual and reproductive health care in the medical county clinics and barriers to that care. And they echoed much of what the providers shared, and I will go through some of the themes from their reflections. So privacy concerns was a big concern from the youth as well. One of the youth describes an experience going to the doctor where the group home staff gave the doctor a form to fill out that had places to put a lot of information, and that created concerns about how much of the visit with the doctor would be private, given that the group home had requested some of this information on the form. Another theme from the youth was the idea of access to care. Excuse me. And so, as one youth stated, I had to ask the group home staff to make me an appointment because the group home knew we were supposed to be where we were supposed to be all the time and controlled all of the transportation. And I was not allowed to make doctor's appointments for myself. So this idea from the youth that they felt that they had limited access to care and couldn't navigate this system on their own and independently. Another theme from the youth was the desire to have continuity of care, and Rebecca touched on this earlier in the presentation. As one youth stated, personally, I did not have any regular clinic or any type of provider as a teen. I moved around too many times, over 16 different locations just in high school. And so really this inability to access the same caregiver over and over disrupts care and makes it difficult to form a relationship with a provider to really address some of these sensitive and confidential topics. And the last theme from the youth perspective was the need to have culturally responsive and trauma-informed care. So as one youth stated, when I went to the doctor asked if I had ever had sex. I didn't know how to answer. I went into foster care at 6 years old and I had an STI then. Does that count? I try not to tell people that because I feel like they judge me and I think I'm dirty or something, but I was just a kid. So this idea that a lot of our patients have a history of sexual abuse, physical, emotional abuse, and that in the care of our patients, we need to be culturally responsive and trauma informed, and our providers need to be trained in this. So now, equipped with both the provider and the youth perspective, we embarked on a pilot project to create a role for a reproductive health navigator in our clinics, with the hope that this team member would help youth with sexual reproductive health plan creation and execution in a culturally competent and trauma-informed manner. But before I discuss the reproductive health navigator role, I want to say that a low-hanging fruit that we also simultaneously tackled was our clinic environment and looking to see how we could make it more adolescent friendly. So I'll talk about our clinic process map and how we looked at the flow of the clinic to address these opportunities, and then we'll go into our pilot health navigator program. And, I encourage you, whatever profession you come from, as you listen to this session also to take some time and reflect on the last time, perhaps if you are a medical provider, that you delivered care to an adolescent patient, or if you're not, that you went to a medical provider or took a family member to a clinic. Think of all the steps that you went through from check-in to check-out. Think about the waiting room, the intake room, the exam room, the check-out process, and think about how that affected your comfort during the visit and your willingness or your patient's willingness to open up during that clinic visit. So as such, we analyze the flow of our adolescent patients from check-in to clinic check-out. And in doing this exercise, we realized, for instance, that adolescents were filling out forms with sensitive questions while waiting in the waiting room seated directly next to their caregiver. We realized through this process map that it was really important to give our adolescents a private space to answer the adolescent health questionnaires, as well as ensure that they were in a private room when the nursing intake was done and depression screening was performed, or questions about a last menstrual cycle were obtained. So in looking at our flow through the clinic and recognizing these opportunities for improvement, we started to bring all adolescent patients into the clinic by themselves first at the beginning of the visit, and having the caregiver wait in the waiting room from the start of the visit. And this is really to set the stage that the appointment is about the adolescent, and that from the start, to really enforce their right to privacy and our need to maintain confidentiality. We continue to work on ways to have adolescent-friendly materials on display in the clinic, as well as clear language about what the clinic does to protect youth privacy. And I encourage you again to think of your last clinic visit and how this sort of process could be applicable. I think it's really important before embarking on any intervention for adolescents in a clinical space to really address these low-hanging fruit that can be changed through rapid cycle quality improvement projects with very little resource needs. So we have discussed a lot so far. You heard from Rebecca about the sexual reproductive health disparities among youth in care. We also spoke about provider and patient perspectives on barriers to receiving sexual and reproductive health care in the medical setting, and specifically in a medical clinical setting serving welfare-involved youth. And I just reviewed how it's so integral to examine the clinic environment when considering any intervention. So now, with the last segment of our session, I want to discuss our Reproductive Health Navigator pilot program, which is an effort to assist our patients with sexual reproductive health education, as well as care plan creation and execution, the goal of supporting our youth through decision-making and follow-up. We're going to discuss what has been written about health navigators in a clinical setting. And then I'm going to discuss the design of our program, including the recruitment of our navigators, the training of our health navigators, how they were integrated into the clinic, as well as next steps. And you will have the opportunity to hear from two key stakeholders in our clinic about their experience with this pilot project so far. So currently, there's no literature to date on the integration of a health navigator in a medical clinic serving welfare-involved youth, and specifically using a health navigator to address the sexual reproductive health questions and needs of this patient population. McKinney et al. Published a review article in 2018 in the American Journal of Obstetrics and Gynecology titled Patient Navigation Across the Spectrum of Women's Healthcare in the United States. And they build on the idea that, or the concept that patient navigation has been very helpful in obstetrics cancer care and gynecologic cancer care, and that patient navigation can be helpful in reducing disparities in healthcare access and health outcomes. And they propose its application across different aspects of the obstetrics and gynecology field. They discuss in this paper the core principles of patient navigation, as shown here in Figure 1, patient navigator model, and that really the role of the health navigator can go beyond a single visit and can really help patients with the 3 tenets shown in this figure. So promoting self-efficacy, enhancing access to care, and sustaining patient engagement in care. And these aspects were all seen as very important when we spoke with our provider and youth stakeholders. They also describe in the article how patient navigation can be used in the realm of family planning, as highlighted here with the yellow arrow, to achieve these 3 aims of enhancing access, promoting patient self-efficacy, and sustaining engagement with the healthcare system. So building on this article and others describing the role of patient navigators in various settings, we set out to build our patient navigator program at the All of You UCLA Medical Center Hub. We hosted 2 summer interns in the summer of 2020 from the UCLA Fielding School of Public Health to help us build the foundation for a health navigator program. They helped us with conducting a literature review on the role of health navigators in various clinic settings and the important tenets of a health navigator role. They also did asset mapping of the reproductive and sexual health resources located near our clinic spaces for our health navigators to access in the future when linking patients to services. For the health navigator role, which began in the fall of 2020, we recruited students from the UCLA Fielding School of Public Health who were involved in the Bixby Center of Population and Reproductive Health. The health navigators, it was essential to us that they went through training. They completed the Essential Health Access Family Planning Health Navigator Certificate Program and received certification as a Family Planning Health Navigator. Myself and my colleague, Dr. Sonal Desai, who you will hear from in a bit, as well as a 4th-year medical student entering OB-GYN, also met with our health navigators every week to discuss the curriculum components and how it applied to their integration into the clinic. We also supplemented their education with discussions on LGBTQ issues, men's health, as well as adverse childhood experiences, trauma-informed care, and details about the child welfare system and nuances in Los Angeles County. So we set up a framework for the navigators to integrate to the clinic and to follow up with our patients. We wanted the navigators to meet not only with patients who expressed concrete sexual and reproductive health needs, but all adolescents, knowing that many of our adolescents may underreport some of their concerns due to the issues surrounding privacy and other things that we talked about earlier, and they may not be prepared in that initial visit to ask many of the questions that they have, but yet we know that sometimes this is a single touch opportunity and we really want to be able to maximize that. So you're going to now hear from Dr. Sonal Desai about the integration of the health navigators into our clinic setting. And then I will transition to a video by Haley Broder, one of our first health navigators, who's going to share some details about her role in the clinic, as well as reflections on her experiences. So here I will load the video by Dr. Sonal Desai.
Hi, everyone. My name is Sonal Desai, and I'm one of the pediatricians in the Hub Clinic. I just recently started helping Stacy with this project and really excited about all the progress that we've made so far. We just launched the Navigator program in our clinic last month. So I'm just going to kind of briefly review how we've done that. Right now, we're having our navigators call patients a few days prior to their scheduled medical appointments to kind of explain their role in our clinic and establish rapport so that they feel hopefully a little more comfortable in talking about sensitive issues, both with the navigators and with the medical provider. Unfortunately, due to COVID, we've been unable to have face-to-face counseling sessions with the patients, but have set up video visits and seems to be going pretty well. During these counseling sessions, navigators have open-ended conversations with patients about things like sexual health and orientation, contraception, STDs, etc. One of the more common scenarios that we've been encountering during these visits are typically adolescent females that are interested in contraception, but are unsure about some of the various methods out there and would like to learn more. So our navigators are very well versed in being able to talk about the options, how they work, potential side effects, and just overall efficacy. Other topics that our navigators are well trained in are discussing things like sexual health in LGBTQ populations, general questions regarding puberty and reproductive health. After the scheduled counseling session, our navigators again reach out to the patients to follow up on their previous conversation and discuss any resources that might have been utilized. And the goal of this phone call is to, again, continue to build that relationship of trust and confidentiality between the navigator and the patient. Right now, our team is currently meeting once a week to sort of review any patient cases that might have come up and discuss opportunities for improvement as time goes on. As I mentioned, COVID has made our patient volume a bit lower than we'd hoped, but we're hearing really great feedback from some of our navigators. Thank you so much for your time.
So now I'm going to transition to Haley, who is one of our first health navigators.
Hi, my name is Haley Broder, and I'm one of the health navigators in this pilot program. And I'm going to tell you a little bit about the program and what we've been doing and how it's been going so far. So first, we are calling all of the patients that are being seen at Olive View right now that are between the ages of 12 and 18 or in the foster system. And so we're calling them before their appointment with a doctor to kind of go over what the clinic provides and review that with them. We're calling them after their appointment when we set up a video appointment with them. Those are usually around like 45 minutes or so just to answer any questions they might have. And then we're following up with them afterwards to review any questions they might have had after their appointment, what they've kind of thought about after and produced, and to kind of provide that continuity of care. And so in these video appointments, that's kind of the bulk of our appointment in our work. We are answering any questions they might have about reproductive and sexual health care. We're normalizing these conversations. I start out by saying, I know that this is a really, really uncomfortable conversation and topic to be discussing, but we are here to lay it all out there. This is a safe space for you. It's confidential. We go through confidentiality, and we try and make it as much of a safe space for them as possible. We build rapport with the continuity of the first call, then they see the doctor, then the video call, and then the follow-up, and we're able to kind of be a space for them to ask questions they might not feel comfortable sharing with anyone else. So I start by talking about, this is an uncomfortable conversation sometimes, but that's okay. This is what I'm here for. And we talk about consent, STD prevention. We talk about harm reduction sometimes. We talk about birth control options, and really any questions they might have around sexual and reproductive health. And we've gotten so many different questions that people might not have felt comfortable talking to their doctor about, and I can kind of pass those over to their doctor and get them answered for them. Or we talk about things that they might not feel comfortable talking to their foster parents or to their group home about. And we're also able to refer them to resources like Planned Parenthood or Bedsider, or to get more information in other sources. So I had my very, very first patient. It was an incredible conversation where she was telling me that she didn't feel comfortable telling her partner that he needed to wear condoms. And she said that she really wanted to wear condoms and he wasn't interested. And so we did a role play and kind of went through how she could tell him what her needs were in that situation. And during the follow-up, she was telling me like how empowering that made her feel, how empowered that made her feel, and how special that was for her, and how she was going to be able to put it into practice. And then just yesterday, I had a patient who was 15 years old and identifies as a gay male. And he was saying that he doesn't feel comfortable asking a lot of the questions to his foster family, but had so many questions about sexual health and as it pertains to gay men. And so I was able to answer some of his questions, go back to his doctor, and work with him to be the best support possible. And a lot of times I think it's just answering the questions as they come up and normalizing that any question they might have is totally normal, and it doesn't have to be that they're relying on Dr. Google to answer these questions. They can come to a real person in the clinic and get these questions answered. We're also able to talk to people, clients, about their options for birth control, helping them decide if an IUD or the pill or the patch might be their best option. And that has been really, really helpful too, to kind of provide that education and that background of the landscape, because sometimes it's really, really overwhelming. And this kind of normalizes it, puts the conversation on the table and says, what questions do you have? How can I help? How can we answer them? We are here for you. So I think the pilot program so far has been extremely, extremely helpful for the patients that we've talked to. It's been great for me to be able to see kind of how their questions have changed from that first call to the video to afterwards, and be able to follow up with them and see how they're doing. So I am really happy to be part of this pilot program.
So great. Wanted to incorporate voices from our team. So thank you to Dr. Desai and to Haley for putting those videos together. Our health navigators just started meeting with patients in January of 2021, so just this year. So it's still very early in the pilot. And as Haley and Sonal both touched on, they have a direct relationship with the patient and with the medical team. And their role is not to replace these conversations by the medical provider, but really to supplement and enhance the discussion. And for the health navigators to know that there's this bi-directional support as well from the medical team, and that the group can also meet on a weekly basis to discuss how the week has gone, what questions the health navigators have had, what pain points they might have, and also to think of opportunities for improvement in the program. We very much look forward to continuing our work with this Health Navigator pilot project as a sub-grant awardee of an innovation and impact grant through the Health and Human Services Office of Population Affairs. We want to move forward with the evaluation of our work so far, and we need to determine if this work is worth replicating, if we should scale this work, what changes should be made. And we look forward to this evaluation piece, both hearing from the health navigators and hearing from our patients in the future. And we thank our collaborations again with the National Center for Youth Law and the Reproductive Health Equity Project for Foster Youth, as well as the HHS Office of Population Affairs for this innovation and impact grant to continue this work. So I want to conclude with a summary of everything that we've talked about. We've talked on a number of different topics in this session. You know, Rebecca touched on the unique sexual and reproductive health disparities and the unique barriers to care experienced by youth in foster care. We talked about how and showed how engaging the provider and patient stakeholders can really help to understand barriers to sexual and reproductive health care in a medical setting, serving foster youth, and that it's paramount to engage these stakeholders to design interventions to overcome these barriers to care. We also discussed how it's important to really assess the clinic environment with the goal of being adolescent friendly and to understand how a patient moves through the clinic and what opportunities there are to maximize the different aspects of that environment to really optimize the success of the visit and to optimize the success of any additions like the health navigator into the clinical setting. And then we discussed how patient navigation is being piloted at the Olive U UCLA Medical Hub to address and mitigate barriers to sexual and reproductive health care for foster youth. And you heard from two of our clinic members about their experience with this. So I want to also acknowledge that it takes a village and to put this project together and to move it forward. I really want to thank our partners at LA Rep, Rebecca, and our partners at UCLA and our collaborators at UCLA, as shown here on the slide. This project would really not be possible without the collaboration and amazing thought partners that we have from across multiple disciplines. And as such, Rebecca and I would love to hear from you. We'd love to hear about your experiences, about your reflections. And if you have any questions or comments on this project or ways to replicate this in your clinical setting, please feel free to reach out to us. Our email addresses are here. We really thank you so much for taking the time to listen to our session and for all that you do to support adolescents in the work that you do. So thank you. Have a nice day.